All right, good afternoon, everyone. It's so nice to sort of see you virtually in this format. I'm a judge in Lane County, Oregon. I like to say a few statistical things about Lane County, which I think are cool. Number one, we are bigger than the state of Rhode Island, so that's nice. We also are sort of a mid-sized jurisdiction. We have approximately 350,000 people in Lane County, and numbers always changing. Today we are at 35 degrees and foggy at my house, which is also known as February. I've been on the bench since 2015, and I hope that throughout this interaction today, we'll be able to have some conversations in addition to just having Dr. Franklin and I chatting. So I hope you are in the mood to engage today. Dr. Franklin.
Thank you, Carrie. Yes, my name is David Franklin. I'm a neuropsychologist. Been with the University of California system for the past 26 years. I am now started at University of California, Irvine, and now at University of California, Riverside School of Medicine. Part of my role within the university, of course, is seeing neurodegenerative illnesses, as well as I am the director of the Elder Abuse Forensic Center for the County of Riverside. That has been funded by the VOCA grant. Through California Office of Emergency Services. I've been doing capacity assessments for quite a few years, as well as doing expert testimonies for the DAs and law enforcement and capacity concerns. So thank you for coming. Wish we can meet personally, but considering the days and times, we will have to do this virtually. So I hope you enjoyed today's presentation.
Okay, so let's start with having some conversation about the types of cases that we're going to see capacity issues arise in. And so we have a poll, and if you could just give us a sense of your particular experience, then we can maybe craft the webinar to be most useful to you. So if you take a minute to fill out the poll, and then we'll reveal the results. I know some folks that are attending today are likely in a specialty court where you may be dealing with guardianships or conservatorships routinely and exclusively as part of your assignment, but you may be like me, a court of general jurisdiction where we see things in a variety of areas. Okay, that's pretty much what we expected, that we would see that there's a lot of ways that capacity issues are overlapping in all of the cases that we're seeing. And while there are lots of issues related to elder abuse, this is actually a class that was carved out of a several day long CLE. We're really going to be focusing on the capacity issues today, and particularly getting you some tools to be able to evaluate capacity from a neutral and fact-based perspective. And so we'll also get some pretty exciting science from Dr. Franklin that might be able to assist us with those decision makings. So, our learning objectives, what we hope you're able to gain is that as a result of this particular webinar, that we remain focused on assessing the least restrictive alternatives for the elders that are in our proceedings. We want to be able to be thinking about how do we approach these cases to really get to the heart of capacity issues and evaluate that information, not based on our own sort of perspective or life experiences, but rather that we're looking at them from neutral and fact-based perspectives. We want to be able to evaluate the information from a variety of sources: medical, psychological, witness presentation, and testimony, and be able to craft orders that are preserving the rights of the folks that are in front of us, while also holding folks accountable in situations of elder abuse.
All right, thank you, Carrie. So let's talk a little bit about cognitive decline. As it can be caused by disease of the brain or in the absence of disease of the brain. So when we think of disease of the brain, we sometimes think of neurodegenerative illnesses, Alzheimer's disease, vascular diseases, and other atypical type of disease states that can affect cognition and cause a neurodegenerative process. And we mean neurodegenerative, meaning that we expect some type of progression of memory loss or other cognitive facets that affect our everyday functioning. In the absence of disease, these can be issues like traumatic brain injuries, right? Individuals who suffer moderate to severe traumatic brain injuries, either by car accidents or by anoxic events, such as strokes and things of that nature. And these are in the absence of a neurodegenerative process, but there are significant cognitive deficits that affect their capacity. Let's talk a little bit about the aging brain. Unfortunately, as we get older, we do not get quicker in cognition. So in fact, we tend to slow down a bit in cognition as we get older. It's something we call fluid intelligence. So it's our ability to do things in a speeded manner or in a very efficient manner. As we get older, things just takes us a little bit longer to get done. We're just not as quick as we were in the 20s, 30s, and 40s. It enables us to hold multiple pieces of information into our mind. It's something we call working memory skills, right? Being able to do things like arithmetic really fast or being able to count change really fast. Well, the way we measure this is sometimes having our patients do digits or numbers forwards and then backwards and then sequencing and see how that parts of the brain work. As we get older, this becomes more difficult. It helps us apply rules or logics to make decisions. And it's very important in financial decision making, as sometimes it's expected that we make decisions on a pretty quick basis, right? In a very timely manner. Okay, next slide. So, as we mentioned, decline in fluid intelligence may not impact ability to care for oneself, and it usually doesn't. It just requires more time to get things done. As fluid intelligence declines, there is something called crystallized intelligence, and this is information that's been with us for a very long time. Whether it's word knowledge, right, vocabulary, it's been there since we were, about the age of 5, 6, or 7. We began to talk, comprehend language. These are stores of knowledge, so fact-based, such as who developed the theory of relativity, what is the capital of Italy, things of that nature. These are all stored memories, and these are information that usually remains intact over time. It has irregardless of speed, right? And so that's something to be take a look at when we deal with capacity. And it's really these stores of knowledge, the crystallized intelligence, that really remains intact when we don't have a neurodegenerative process involved. But individuals who suffer from Alzheimer's disease, which is a type of dementia, when we look at dementia, it's really an umbrella. And underneath that umbrella are different spokes. And there's many different types of dementia. The most common, of course, being Alzheimer's disease. Then there's vascular disease or dementias due to strokes or what we call cerebrovascular accidents, or sometimes Parkinson's disease or Lewy body disease. And so there's different types of dementia. Under this umbrella is also called mild cognitive impairment, what we call now a mild neurocognitive disorder. And these are impairments that we're starting to see, which are early in the process. We start seeing cognitive decline, but it has yet to affect their functioning, an individual's functioning, whether they're able to cook for themselves, do the finances, drive, things of that nature. These deficits, although we're seeing them observationally, may not be impacting their everyday living. Okay, next slide. So when we talk about mild cognitive impairment, it is at less severe than a dementia. It's usually the early stages of a neurodegenerative illness. And it could be caught somewhat early. There are medications we can use to help slow it down. However, this is the beginning of something like an Alzheimer's disease. Progression may be staved off for about a year or two, but we do expect some type of progression. Again, what separates a mild neurocognitive disorder or MCI from a major neurocognitive disorder or dementia is really the lack of impact in the individual's activities of daily living, right? They're still able to dress themselves. They're able to make change. They're able to balance their checkbook. They're able to drive without getting into any issues, things of that nature. And really these individuals for the most part have capacity. There would be no reason why they wouldn't have capacity. About 1/3 of people with MCI will develop dementia within 5 years. Okay, next slide. So dementia. Unfortunately, the greatest predisposition to developing a dementia is age. As we grow older, the risk of developing dementia becomes more prevalent. Nearly half of those over the 85 will suffer from Alzheimer's disease or another form of dementia, unfortunately. We can do things to help our heart. We can do things to help our lungs. We can do things to help our kidneys and liver over these ages, but the brain will tend to deteriorate over time. However, with individuals who suffer from these neurodegenerative illnesses, they deteriorate at a faster rate and cause more difficulty for that person. Unfortunately, this is also the fastest growing segment of our population is individuals who are going to be over 85. Okay, next slide. All right. So let's talk a little bit about discussion here. How and when does an individual's capacity arise in your cases? Okay.
And
Anybody
this.
have any input? Carrie?
Well, I'm going to take a look and see if we have folks responding in the chat, which is a little bit difficult for me. But Amanda's going to help me with that. So I think one of the things that's interesting about what Dr. Franklin was mentioning, I like numbers, I like statistics. I think that's interesting, data-driven information so that, I can make good decisions. And so, I'm the kind of person that when I look at the last slide, I think, oh, everyone over 85, half of them are going to have dementia or Alzheimer's. And that's exactly what we don't want you to take away from this particular presentation. Only in that you have to remember that each person needs to be evaluated as an individual and evaluating the facts and circumstances of your case. It's important to have the knowledge, but not come to your proceeding with that preconceived notion. So, when we did the polling to find out which types of cases you're seeing capacity issues in, we sort of saw that that was an issue that was occurring across the board. So we might see them in, I have my chat up now. So, okay. So Judge Zen says, deciding on whether to establish the guardianship. That's the first place that we sort of think of when we're going to be evaluating the scientific evidence. Do they have that capacity? Is it appropriate to appoint counsel for that person? Also, you'll see Judge Long says at all phases, it would be nice to address the individual's capacity at the beginning of a case, but that's not always possible. And why? Because we may not have all of the information and facts as a case gets started, but they reveal themselves to us over time. And so when we're looking at capacity issues, do we have that preconceived notion when they come into the courtroom? Are we looking at someone and saying, you are over X age, therefore you might be incapacitated? Or are we waiting for that information to come to us through some other avenue? It's important to be thinking about if they have some level of impairment, regardless of the type of case that's before you. What type of impairment is that? Is it a limited impairment, such as understanding that they still have the ability to provide for their basic needs? Or are they having some larger degree of impairment that might affect their ability to make everyday decisions, to recall events, to testify? I see another note in the chat that says, for example, in guardianships proceeding, an alleged incapacitated person may want to represent themselves or fire their court-appointed lawyers and hire an attorney of their own, which their competing children might also then help them find or not find. So these are all really difficult parts for us to struggle with on the bench. At what point are we making capacity determinations? Is it very early on in the proceeding? Does it reveal itself later? And then what sort of actions can we take to make sure that people's rights are preserved, but that we're also upholding sort of the integrity of the court process? Next question. What does the information you just heard from Dr. Franklin mean in terms of older litigants? I think I think that I'm covering that, or at least I hope to be covering that, in remembering to challenge ourselves in the way that we think and the way we are viewing people. And we'll have some examples for us later on in the webinar of more generalized kind of fact patterns that we see in our cases. But be thinking about this information from Dr. Franklin and how am I going to incorporate that in how I approach cases in which capacity is an issue. If it's family law cases, if it's elder abuse cases, if it's your protective order cases, what do I need to know?
And Carrie, I'd like to expand a little bit on this as well too. And when we mention dementia, just because someone's been diagnosed with Alzheimer's disease does not automatically pertain to that person losing capacity. And that's why really these assessments are incredibly important to be done accurately, because even though someone suffers from Alzheimer's disease, at the beginning stages, they may be able to drive, and that's really done by the DMV, right? And they may be able to make decisions and have capacity in all facets. So it is really important to have an examiner do this that understands that part of it, and not all of a sudden assume that someone who's 90 years old who has maybe suffering from early stages of Alzheimer's disease automatically doesn't have capacity, right? And I'll be restating this throughout the talk today as well.
All right. So, as we deal with capacity, it is sort of an interesting paradox in the law because capacity can be evaluated legally, we know, in a variety of situations. For example, we can evaluate capacity independently to determine such things as the ability to craft their will. Did they have capacity at the time of crafting of the will? Do they have capacity at the time they entered into their marriage? Did they have capacity when they entered into contracts? Do they have capacity to vote, drive a car, stand trial in criminal proceedings? So we look at those things individually on a fact by sort of on a case by case basis, right? And that's fact driven. But for whatever reason, once we start talking about elders and guardianships or conservatives, whatever you may call them in your state, for whatever reason, the law developed over time to sort of be this blanket determination of incapacity, which then results in a intrusive curtailment of their autonomy, a basically stripping of some basic human rights. And so the laws have been evolving. You know, we have a nice collection of information on the conservativeship or guardianship laws throughout the states. And we are seeing the trend that is changing those statutes. And people are getting educated on the fact that blanket guardianships or blanket rules that are stripping those rights are not the right approach. Let's craft something that's actually meaningful for this person in this particular set of circumstances. Um, so, as I said, we do have a repository for guardianship laws or conservatorship laws throughout the state. If you ever need help with that, I'm sure someone at NCJFCJ can help you compile that. If you're looking at your statutes and thinking, well, maybe we need to get a little bit more up to speed and be including language like crafting orders that are least restrictive. We do know that as a result of research that was done, that our guardianship laws vary throughout the states, but generally speaking, there are four sort of varying tests in determining incapacity. Does the person have a disabling condition? Is that resulting in their inability to provide for their basic needs, sort of on that functional basis? Do they have any cognitive impairment and impairment to their cognitive functioning? And then some sort of finding that the court has to make. And this is what we're going to be talking about today. Really be thinking about what's necessary and what is least restrictive. All right. So craft to fit your facts and circumstances at the time. Let's see. All right, let's go into the concepts of capacity and get more science from Dr. Franklin.
Great, Carrie. All right. So when we think about capacity, it really is a continuum of decision-making abilities, right? From the simple to the more complex. And when we look at capacity, as Carrie had mentioned, it is really at the individual level. And we want to keep it at the individual level. And capacity could be can be situational. Is it financial? What happened at that point in time? Was it a sweetheart scam? Was it some type of financial abuse that was inducing it? What was that person's understanding and appreciation of that situation? Really, capacity, when we look at each individual, is contextual. Okay, so we take the context of what's happening at that point in time. We stay away from the global complexities of capacity and really try and hone it down into where we think the capacity is, or where the abuse or the difficulty is that an individual may be suffering from. So we try and make it as honed in as possible and understanding the difficulty noted with this individual, right? And in the state of California, we have capacity when we look at either the person or is it a state, and really trying to divide those situations up. Is the person able to care for himself, but isn't able to handle his or her finances, or needs, needs some type of assistance in handling these financial or state issues, and really getting a better idea of what's happening at that point in time. It really varies by the complexity of the task to be done, right? Or decision to be made. The more significant the decision and the consequences, the higher level of capacity required. the higher level of thinking, right? As what makes us humans different than other primates is the way the brain develops, from old regions that are very deep in the brain all the way up to the higher level of thinking, or the cortical region of the brain that really kind of makes us different than other primates. The ability to for us to make those decisions and problem solving skills, either fast or being able to have time to make those skills, requires different levels of capacity, and how that individual is appreciating those different levels is really important in understanding capacity. Next slide. It is task specific, not global, as I mentioned before, right? Is a person able to balance the checkbook? Is there a possibility of undue influence or things of that nature? And we'll get a little bit into that, not too much, but is a person entering in a contract? Was there cognitive impairments done at the time of the contract? Within our center, we do something called time stamping. So in other words, a person signs a will or estate over to another individual, and Adult Protective Services is concerned regarding the person's cognitive awareness or appreciation at that point in time when the contract's been made. Um, we can take a look at medical records and decide if the person was hospitalized or seeing doctors at that point in time. What was the person's mental status at the time they made that contract? Okay. What was it when they went ahead and changed the will or estate to this other individual? Were they in the hospital at the time? Were they suffering cognitive impairments? What was their capacity like when they made a gift or managed their finances? Okay. Engage in complex planning and execution of steps. Is the person able to plan ahead? Is there some type of organization and planning? And we can take a look at this with some of the neuropsychological instruments that we try to use for our assessments of what's called executive functioning skills, right? Our ability to organize and plan information. Are they able to care for him or herself, right? Are they able to go ahead and take showers without being prompted? Are they able to toilet and being able to dress and take care of the house and things that nature? Are they able to do these things? And that's one of the issues that we take a look at the capacity of a person. Okay. All right. Capacity can fluctuate. And this is some of the difficulties that we have during capacity, or dealing with capacity. There's this nasty illness called an encephalopathy. It's a fancy word for delirium, okay? Where we can have infections that changes someone's mental status, right? I myself try to stay away from making capacity determinations when someone's suffering from a urinary tract infection that hasn't been treated. So taking in instances like that, you have to, the clinician has to understand the medical condition of that individual at that point in time. Okay. And we try to be aware of those medical conditions. Medication can severely influence cognition and thinking. So understanding what medications that he or she is on, medications that handle issues like urinary retention, or someone that suffers from urinary incontinence can cause significant cognitive issues. Certain anti-epileptics or medicines that we use for seizures, right, can severely affect cognition. And so understanding how medication may be contributing to a person's mental status. Time of day. Okay, many of us have heard of sundowning, right? As we get throughout, as we move throughout the day, an individual's mental status may change. You kind of may see this with children, right? The ages 3 to 6. So as they get older, as they move through the day, they become more irritable. They become more angry, and they need a nap, right? Well, with some of our older adults, you can see these type of behaviors as well too. The agitation, sometimes anger, but you can also see this decay in mental awareness as well too. I myself take the practice where I don't do assessments at that point in time. I do the assessments when they have the best capabilities at that point in time. I really look at capacity as being really, if guardianship is needed, this is the last determination. So I really want to understand what that person's capacity when they're at their best. Events in a person's life, grief, loneliness, depression, can severely influence one's mental status and cognition. If you can imagine someone that's depressed, they're not maybe thinking as well. Memories usually some can be impacted. Attention and concentration can be impacted. An individual's mood status can really impact one's cognition. So sometimes treatment with SSRIs or antidepressants can actually improve cognition because you're treating the mood. Again, does that person meet the threshold of capacity? Most likely not. And looking at treatments to try and improve certain either mood issues or medication issues can really affect one's mental status. Experience and education may be relevant, right? Literacy and extended education may be related to ability to understand complex financial transactions. So really talking at that level. If you have a person that's educated at the 10th grade level or ninth grade level, grant certain contracts may be written in a way that is much more complex than what they're able to understand, and taking that into consideration. Language capacity may be relevant to ability to understand as well too. So understanding language, semantics, determination of language may also impact one's ability to appreciate and understand the situation. Next slide. Mental capacity really includes the ability to think clearly, right? It has the ability for the brain and certain regions of the brains to be efficient when thinking, to be somewhat speeded, to understand that there's consequences to each decision, recall accurately, right? So whether it be in conversation or whether it be signing certain contracts or time relationships, thinking that you were at an attorney's office yesterday when you were there 2 months ago, right? Understanding these situations are incredibly important when you look at mental capacity. Organizing one's thoughts and planning to come to determination is important. Oops, can you go back? There we go. Thank you, Amanda. Express thoughts through communication. And this is really important. Language, being able to articulate one's thinking and how they arrived at that thinking. Individuals who suffer from neurodegenerative illnesses, early Alzheimer's disease, you can actually see what's called thought blocking, where the individual is having trouble finding words to express his or her thoughts. And we can identify these through certain neuropsychological assessments. And so sometimes we have patients that come in and thinking they have tip of the tongue. They're just having trouble finding words to complete their thoughts. And this can be as a sign of early neurodegenerative process. Now, I'm going to put in a caveat. As I myself have gotten older, finding words to express our thoughts is common, right? And it happens as we get older. Not all of these are attributable to a neurodegenerative process, and that's really important to understand as well too. We're looking for impairments that are above and beyond age norms, right? Above and beyond someone who's in their 50s and 60s, and really observational, right? Where a family member comes in and they're just like, they're calling objects different names or having trouble finding names of individuals that are well known to them. Plan and execute actions. This is really one of the foremost issues that we see with individuals suffering capacity issues. It really has to deal with the frontal regions of the brain. To be fancy, it's really levels in the prefrontal cortex, or the front part of the brain. It has to deal with an area called the dorsolateral prefrontal cortex, which is in the very front part of the brain to plan and execute actions. Really to be able to organize and plan information. And this what really attributes to dysfunctional abilities to care for oneself, especially dealing with finances and contracts and language. This part of the brain is really important in understanding capacity and how that's affecting one's ability to care for him or herself. Next slide. Okay. So having adequate capacity is a judgment of a person's decision-making abilities, right? Being able to understand the choices that he or she is being confronted with. The reasoning behind making that choice, right? Understanding and appreciating that choice. Now, one of the difficulties that we have, especially when making capacity, is that there's this really difficult reality called free will, okay? We know that betting $100,000 on black may not be the best thing to do for someone who is 65, right? But if he or she really understands the consequences of that, and that's his or her choice, then that really is his or her choice, right? We deal this with sweetheart scams too, right? Where someone befriends an elder adult, and understanding that there's a choice and consequence when dealing with people that they don't know very well, and understanding the decisions and making those choices. It is really difficult to have anyone sit in front of you and fail, or understand that there might be some type of failure there. But if they understand there could be a consequence of failure, then that really is determining the person's free will. And that's what makes this really difficult. It's kind of having a teenager make decisions that are not good for them and holding back and watching to see what happens. You try to prevent it the best you can and educate that individual. But at the same time, there is that free choice and free will in making these decisions. Okay. Next slide. Executive functioning. And as I mentioned to you before, this is really the crux of what we see in individuals where we see a deterioration in one's ability to care for him or herself, to understand how this affects financial transactions, how we're able to balance our checkbooks, how we're able to use electronic devices and things of that nature. It's usually dominated in the front part of the brain, the prefrontal and frontal regions of the brain, as well as the temporal regions can affect executive functioning skills as well too. And it's really the ability to plan, to evaluate steps and alternatives, to problem solve. Critical and financial transactions, absolutely. Understanding and appreciate the financial transactions, right? Can have deficits in executive functioning without having dementia or memory impairment. So one of the new things that was determined using our diagnostic statistical manual, the fifth edition, is that we moved away from the idea that an individual with dementia can only be diagnosed with dementia with memory impairment. And that's just not true. Okay. You can have executive functioning deficits and still suffer from dementia without having memory impairment. Okay. And it's usually a different type or form of dementia. It's what we call frontal temporal lobe dementia. Okay. And it usually occurs in the front part of the brains where we see this neurodegenerative process. Again, impacting things like executive functioning skills, organization, and planning. But memory may be very much intact, but the person's having trouble with his or her finances or doing things that are impulsive. Okay. I had a patient who suffered from this type of disorder and ended up shooting a shotgun in his closet and discharging it because of impulsivity issues, right? And it was found that the person did suffer from a frontal temporal lobe dementia, but his memory was definitely intact, but was having a lot of trouble making decisions. Requires alertness and attention, ability to process information efficiently, and really those areas of the brain really modulate mood and affect. And if the person's really depressed and really apathetic, then we start worrying about issues with an early onset of a neurodegenerative process. Then this happens over time. Next slide. So how is capacity assessed? Is there a difference between screening and assessment, right? And let's kind of delve more into the type of instruments that you may see come across your panel or across the courtroom. So the gold standard at one time was called the mini mental status exam. Okay, and this was a 30-point exam. And I'll delve a little bit more into this. There's also another screening for capacity called the clock drawing test. Okay, and I'll describe that in a few. Now that the norm is more of what we call the Montreal Cognitive Assessment Test. It's called the MOCA. And this is something you're going to see probably across your bench or come across the courtroom, hopefully more often now. It's an assessment that's been normed in multiple languages, from Chinese to Korean to Japanese to Spanish. It's got some really good research as to cutoffs that we look for people who suffer from dementias. And then we really look at the neuropsych assessment, right? And this isn't a screening assessment. This is really a full assessment to look at someone's cognition, which can include a clinical capacity evaluation, understand the person's capacity. They can happen one within the other, or we can take a look at capacity different from just a long neuropsychological evaluation. During that time, we can make the medical decision-making capacity evaluation as well as financial capacity evaluations. Lichtenberg came out with some scales looking at person's ability to understand finances and appreciate their decisions when making finances. Sometimes we'll see that tool as well too. Okay, next slide. So the mini mental status exam, as I mentioned to you before, it's a 30-point exam. It's 11-item questionnaire that can be administered in about 10 or 15 minutes. It's a reliable and valid as a screening tool, but not a diagnostic tool. In other words, you may have a score of 20 out of 30, but we may not know what type of dementia it is. We may not know if it's due to vascular reasons, if it's due to Alzheimer's disease, and those type of progressions can be much different animals than what we can see. It's a good assessment. There's been a lot of research behind it, and it does have good cutoffs. So it gives us an idea of how impaired that individual might be. Okay. Next, the clock drawing test. And this is something that we may see either family members go through at the doctor's office, and it's a very quick and dirty exam. Really, the person sits there, draws the face of a clock, puts the numbers oriented within the clock, and then they're asked to draw 10 minutes past 11 or 45 minutes, a quarter to 4, and see how they're able to abstract. And really, we're looking at understanding how they're able to draw the hands in different regions of the clock. What we can see with this, and what can happen often is, well, in individuals who suffer from significant neurodegenerative illnesses, is that the numbers may be drawn backwards. There may be numbers that are skewed on just one side of the clock, which tells me that there's some type of vascular issues or maybe some type of neglect in that region of the clock. It tells me how they're organizing information. It also looks at remote memory, right? Things that have happened. What's our memory like a long time ago? We're pretty used to using the clock. My kids, who's now 11, at the age of 7, still had to know what a clock looked like. They still had to know what the hands look like. So we're not there yet where we're just using digital or digital formats for clocks or looking at our iPads or phones and saying what time it is. We understand what a clock looks like and understands how the hands within the clock work. So when we start seeing impairments in this domain, we're looking at also now long-term memories being impacted, and this can be of concern. Next instrument. The Montreal Cognitive Assessment is what I mentioned before. It actually looks at executive functioning skills as well too, which is very different than what we see with memory with the mini mental status exam. So it gives us an idea what that person's cognitive flexibility is like. Is he able to move from one step, or she able to move from one step to the next? Or are they very cognitively rigid, very narrowly focused? And you can look at that information with that tool. Because that's a little bit more sensitive than the MMSE, its memory tool is also more significant. The mini mental static exam only has what's called a 3-word recall. So in other words, you tell the patient, hey, I want you to remember these 3 words. Say it's blue shirt and honesty. Okay. And then you give them a distractor test. 30 seconds later, they're able to retrieve it. And maybe 15 minutes later, you see if there's a retrieval of those 3 words. With the MoCA, you look at 5 words. So it gives us a little bit more of a breadth of what's happening and how impaired that individual might be. Next assessment. So really the final points of capacity requires an expert's assessment of capacity. You really have to trust that the person that's getting the assessment that understands neurodegenerative illnesses, understands how person, just because they suffer with Alzheimer's disease, doesn't necessarily make them not have capacity to make decisions. So really relying on that expert and understanding that and making sure that they're in the right field in doing this, right? We don't want a pediatric psychologist or neuropsychologist making determinations of capacity of an older adult, okay? And it really varies from state to state. In some state, could be any type of healthcare professional. So we can have a radiologist who looks like at MRIs and they can make capacity determinations, but do we really want that in our courts? No, we don't, okay? Or we can have podiatrists make these decisions. We don't, so we really have to understand the expert's expertise in making these decisions, right? And it really does vary from state to state. Some states have boards to determine assessments and capacities up amongst practitioners. Others, like the state of California, you have to have 3 years experience as a psychologist in geriatrics to do this, or be a physician, okay? Focus on the person's abilities. It is difficult to assess, and really doing, as I've done more and more and more of these, it becomes a little bit, you hone in on those traits. And myself, and what we try and practice and standardize is you come from the presumption of capacity. I walk into a house, and when I do the capacities at homes, which 95 to 99% of my evaluations are done in the home, not done in my office. When I look at presumption of capacity, I really go in with the idea that this person has capacity. Sometimes you walk in a house and you just see it, and I get it. And the place is a mess, trash is not taken out, all the exits are boarded up, the person can't get out, there's no food in the refrigerator. Those are really good signs that the person does not have capacity. That's why I like going into the home. But the courts really must fact find, determine capacity. What kind of abilities are they able to retain? Which ones are they able to keep? Are they able to decide, hey, look, I can decide what kind of food I want? Are they able to go ahead and dress themselves? Are they able to go ahead and pick out their own clothes? Things like that. That's what Carrie is mentioning about looking at capacity not only as an all or none situation, right? But really tailoring it to that individual is really important, and understanding what they're able to do. Not all of my patients need to be locked up in facilities. If we can have a person there watching them, or be in a boarding care or room and board where it's a lower level of individuals there, but they have certain wander guards and things like that out to protect that individual. Those are the type of things you really need to tailor to each individual and tailor that guardianship to make sure it's appropriate, safe, but also respect that older adult. And that is so important. Every time we walk in, I don't call myself Dr. Franklin. My name is David. These people are usually older than me. Okay. And understanding that respect. I don't wear a jacket. I wear a pair of jeans and a button down shirt with my tag on. So really understanding that you're dealing with someone that's, unfortunately suffering from this illness, but also deserves our respect as well, too, being an older adult. Next slide. Okay. So again, looking at capacity versus no capacity, court may suggest other resources to assist the older adult. Can we get the person a payee? Can we do things to help kind of minimize the issues that we're having regarding some of the financial issues or concerns? Can we get a family member more involved? Can they live with a family member? Things that nature. Finding other avenues we can do to help these patients. And really understanding the presence of undue influence, which is kind of a talk in its own, but really understanding how that person's being able to make decisions. Are they being influenced by others? And you don't have to have a dementia to suffer from undue influence. I get this constantly when I deal with expert witness testimony in courts, whereas it's a presumption that you're under the undue influence because you're suffering from a neurodegenerative illness. Absolutely not. The person with undue influence, that individual, the abuser may be maybe isolating that individual, maybe withdrawing that individual. We see that often, okay? And use of tech to leverage resources. In other words, are we able to track them using the Ring? Are we able to use cameras in the home to watch our loved ones or to watch these individuals? Are we able to use phones or other electronic devices to help manage the difficulties that that individual, he or she, may be suffering from? Okay, next slide. All right, Carrie.
All right. Before we get going on this specific example, I just want to point out a few things that I think are important to take away from Dr. Franklin's presentation for us and about how these cases actually present to us when we finally are seeing them in the courtroom, right? Because lots happen to these folks before they ever come through the threshold of someone filing a court case and either being there in person or trying to appear by phone. I think a couple of things that I would urge you to consider. In many of our jurisdictions, we have the same group of people who are doing these types of evaluations for us. We're familiar with their names, they've been around for a long time, or they're just joining your jurisdiction to be able to provide these assessments. Get to know these people. Get to know their practices, get to know the tests that they're using. If you have questions about what you heard from Dr. Franklin and you want to verify with them, how are you conducting these? I think it's really critical that Dr. Franklin points out that he conducts those assessments in their homes when he can. Right. And not that we're saying that that's an absolute requirement for you to have a valid assessment done. However, you can hear how important it is to have somebody have eyes on how they're living, what are their circumstances. If they're only seeing people in the office, then they're only seeing them probably after somebody has cleaned them up, has dressed them, has delivered them potentially to the proceedings, has also, had the opportunity to talk with them prior to the proceeding. We always worry in custody cases when children testify, which parent brought them, who did they spend time with in the car, that type of thing. And so be thinking about in your own jurisdiction who your evaluators are, how they are conducting these. If you don't know, schedule a brown bag lunch. Try to schedule 15 minutes of their time. I'm sure they're more than happy to talk with you because part of the work that you're doing is generating work for them too. So have those conversations, learn how it's being conducted. Also, take a critical look at how folks are conducting these assessments. The science is ever evolving, which is why we have the benefit of having webinars like this, right? The way assessments were done 15 years ago, and maybe when you started your rotation, are not the same way assessments are being done now. So we need to make sure that we stay up to speed and that we hold our evaluators to that same standard. So you now have some lingo, vocabulary, some questions you should be asking about the types of assessments that are done so that you have meaningful tools as you have those conversations. So I have some other points I want to go back to, but I really want to make sure that we have enough time for discussions. And if I have time at the end, we'll talk a little bit about more about when folks are coming to the courts. So let's take an example. I'm sure this is very similar to many cases that you see. So we've tried to make it sort of broadly useful as possible. So let's consider Mr. Need. Mr. Need comes to us in the court system because he was hospitalized with injuries that are consistent with physical assault. And the hospital has concerns about his discharge and wants to make sure that there's a safe discharge plan. So they have filed a petition. So that's how Mr. Need comes to us. Mr. Need is 78. He has no children. He's a widower. His nephew and the nephew's wife have moved into Mr. Need's house. And so what we learned from Mr. Need and from the nephew are a variety of things. First of all, the nephew says that Mr. Need likes to leave home for extended periods of time. We know from Mr. Need that he roams the city by taking bus rides. He sometimes stays with his lady friends. Per the nephew, Mr. Need continually loses his financial information like his ID and his bank cards. Mr. Need's not concerned about this because Mr. Need just goes to the bank and goes to tellers that know him by person and gets whatever cash he needs from those particular tellers. When he was examined, his cognition was determined to be in the normal range, but a physical exam revealed mild dehydration and malnourishment. Mr. Need said at one point that his nephew had physically abused him, but then recanted. We know Mr. Need has been in the hospital 6 times over the last 5 years. And he's telling the hospital that, yeah, he'll stay in the home, meaning maybe not wander quite so much, if the nephew leaves. But he doesn't really want the nephew there. He doesn't think he needs the nephew's help or the nephew's wife's help at the home. So that's the information we have. So, what sort of things do we want to know? Let's start first with the types of, excuse me, I'm just going to go ahead to our discussion points. First of all, let's be thinking about what in the information that I just relayed to you, were there indications that I was expressing some degree of ageism, bias, or prejudice? Or did you, upon hearing the facts, impute and reflect honestly on conclusions that you drew simply based on this limited information? So let's talk about ageism for starts. Go ahead and drop in the chat. I have my chat open and I am ready. What did I do wrong or say wrong? Or what conclusion did you draw that is a broad sort of prejudice or ageist approach? I know everyone's shy. They don't want to say I did anything wrong, but really, have at it. Is there anything I did or that you drew a conclusion about? All right. Well, I don't want to sit in silence for a long time since we're on Zoom, and filling silences has never been a problem for me. So I'll say, first thing I can tell you when I read it, I started reading 78. Maybe I even said 78 with a different tone in my voice. And I think that's important because we're on the record and all of the actions that, well, we're not on the record now, but when we're in court, we're on the record. And all of the minute actions that we take start to affect how other people in the courtroom are perceiving how we treat each other. So if I start saying things that maybe diminish or undermine or draw attention in a negative way to a person's age, if I'm somehow treating them like a child by speaking to them as I would an infant, if I start yelling at them, presuming that they can't hear, those are things that are then starting to shape how a proceeding in our courtroom is going to be handled. And the way we handle it affects how other folks handle it. Okay, so let's move to the next point. When we're looking at this fact pattern, what indications do we have of self-neglect or elder abuse? Now that's an easy one, and you're not going to pick on me by answering this. So go ahead and fill in the chat where all of us can see what you observe as indications of either self-neglect or elder abuse. Dehydration and malnourishment. right? Injuries. When we get information about dehydration and malnourishment, and we have indication of injury, what's our next step in that evaluation? Right. We need to be investigating the causes. The wandering, that's also an interesting fact, right? We put it in there like all law school questions for a reason. We're finding someone that is finding a reason not to be home, right? So we need to find out what is at the root of that wandering. We know that he's been hospitalized for injuries, but we haven't really sussed out where those injuries came from. And some of us, based on the fact pattern, might have presumed that the injuries were related to nephew. Would it be different if the injuries were a result of a stranger interaction at the bus stop? If it's a stranger interaction at the bus stop, how does that affect your analysis? Does it make you think that he's not taking care of himself by hanging out at bus stops at 3 o'clock in the morning in bad neighborhoods? Or does it instead make you think, well, the nephew's not abiding by his responsibilities to care for the uncle that he's living with? There's also in the fact pattern that I didn't read, we talked about the distant relative is involved and needs money. So that's interesting. Why do we think that this distant relative, meaning the nephew, is involved and needs money? That's what we're thinking when we review the facts of the case. So, every bit along the way, we need to be evaluating the circumstances critically. So, what other information do we want to know as we are evaluating? Remember, we are here because the hospital has requested a guardianship for a safe discharge. What else do we want to know in evaluating this case? Is this behavior new or different? Has he always been a wanderer? Has he always disappeared for periods of time, hanging out with his girlfriends? Has he always been sort of more free with keeping track of items like his bank cards and ID? Some people are like that their whole lives, right? Is this new information? And if it's new information, what might that lead us to conclude? And if it's the same information if it's the same conduct that's been occurring throughout his life, does it mean that the court needs to be taking some sort of intervention at this stage? I like Judge Powell's question too. Are there other relatives or other family members that can help? And that's one of the things when we're looking at, are there resources that are available? Is there something short of court intervention that can be done? Or can we craft an order that allows for those other family members or relatives to be involved in this particular case? So I think it's important when we're evaluating things in Mr. Need's situation, when we're evaluating the difference between self neglect and elder abuse. And I think that's a tricky one that a lot of us struggle with. As Dr. Franklin said, a 65-year-old can decide to gamble their entire life savings on Black if they choose, right? So long as they are competent to be able to do that. Is it a great decision? No, but it doesn't mean necessarily that that person is incompetent. So, when we're looking at issues of self neglect versus elder abuse, we're looking for things that a person is failing to do for themselves. And elder abuse is somebody else causing some action that results in similar or same symptoms that we might see getting masked as self neglect. Someone else might be intervening, and then we're in the avenue of really calling this an elder abuse case and getting to the heart of that. So Dr. Franklin's going to talk a little more about the self-neglect versus elder abuse symptoms. Oh, before we do that, I'm sorry, I noticed there's one point that came up in the very last animation, which is in the Harold Need case. So we talked about some of the additional information you want. So has anybody heard enough about the case that they would actually craft an order? So this one might be a little bit easier if somebody just wanted to raise their hand and chat. I can't see that very well. Amanda, if you can see someone raising their hand. Um, okay, let me
I'm not
see.
seeing any hands raised.
No hands raised. Again, you guys are relying on me to fill the silence again. All right. So, some things I would just nudge you to be thinking about as it results to Mr. Need and his circumstances. First of all, I think you have very little information that you can really base a strong opinion on whether or not it's appropriate for court intervention. You have some information about potential. I have to actually go back to my version of the facts just to refresh my recollection. So, we have an examination that revealed cognition in the normal range. I pose to you that that would be a good place to start. Look at your evaluation and your examination because that is your sort of neutral and objective evidence that is giving you insight, right? And once you've learned that the cognition is in the normal range, then you start looking at these other symptoms and determine whether or not a guardianship order is appropriate. If he is able to care for his basic needs, and so depending on what the standards are for your state, right? So it's not only cognitive, are they able to care for their basic needs, right? We find that he was mildly dehydration and mildly malnourished. Does it rise to the level that that would qualify as not being able to care for his or her basic needs? We're also looking at the issue of the nephew. You maybe are going to have to spend some time talking a little bit more about the access that the nephew has to the finances. The nephew is the one that's saying that he's losing bank cards and ID cards. We may be hearing something different from Mr. Need. So I would pose that the information that we have provided here is a great place for us to start our analysis, but you're going to need to be following up with the evidence from Mr. Need, from the treatment providers, from people Mr. Need may want you to hear from, in addition to the nephew and the wife, before you determine whether or not an order would be appropriate in this case. So obviously we pose something here and give it to you as an example of kind of one of those octopuses that like, oh, well, what's the end result? What am I supposed to do? The end result is you're supposed to do your job to get to the heart of what is really going on in this case based on objective, neutral information to the best extent you can, and then evaluating your witnesses and your credibility issues. All right, now we'll move on.
Great, thank you, Carrie. So let's talk a little bit about self-neglect. So when we talk about self-neglect, this occurs when a person fails to meet his or her own physical, psychological, and social needs, right? So this includes being able to keep the home in decent condition, somewhat clean, making sure there's food in the refrigerator, making sure that the person is showering several times a week, that on occasion, and this is kind of more difficult, it's the social needs, right? Understanding that they do have some type of network surrounding them. Other individuals have their own right to go ahead and be a hermit and kind of stay in their own little quarters, but that being able to be checked on and things of that nature. So that's what we look at when we look at self-neglect, and when those things become interfered with. Great, thank you, Amanda. Continue. So self-neglect, signs that we really look at, right? They're some of these are very obvious, right? Malnutrition, has there been a significant amount of weight loss? Hypothermia or hyperthermia, right? Especially low or high temperature burns and things of that nature that we look at. I've had a couple cases in the center where we had elder adults die from being put in baths that are just scalding hot, right? And so you look at when you have witnesses come in front of you to understand that that there are temperatures involved and what those temperature thresholds are. Excessive dirt or odor, again, not showering, not taking care of themselves, and bathing. Hazardous, unsafe, unclean living conditions, exits that are maybe boarded up or there's boxes in front of them so he or she cannot exit the house. Inadequate or inappropriate clothing, when it's 35 degrees out where Carrie's at, we don't want them walking out in shirts or shirt skirt and a tank top, right? And having that individual know that those clothes are dirty or things of that nature. Those are some very much signs of possible neglect. Isolation. This one's I really want to point out because this is something that we can see, especially in the abuse realms and undue influence realms, where we see individuals that are having loved ones or people who they do not know not with or withdrawing from their friends, church, social support services. And you can see these individuals really isolate. And that's a real concern. And that's something that I see often come in through the center. And it's something we take very seriously. Absence of needed glasses, hearing aids, unexplained deterioration of health, bed sores, decubitals, decubes, things that nature, and what stage those decubes are at, how significant those decubes are. There's also signs of neglect, signs of excessive drugging. I was just involved in a case where the person was given excessive amounts of phenobarbital, which is a barbiturate, an old medicine used for seizures. And then at the time of the drugging, signed over a will and estate. And within 2 weeks, that person passed away. Needless to say, the DA's office got involved, and that person was convicted. Refusal to take medications or other drugs of misuse. Okay. Learning points, but these can also be seen by abuse perpetrated by others as well too, right? And so that's something that we really take seriously. The idea of withholding food, the idea of withholding water, the idea of withholding meds, the idea of withdrawing and isolating that individual, right? Those are all signs of possible abuse done by others, whether they're loved ones or whether they're people that are befriending these individuals for financial reasons, right? And this is something that should always be vetted with those cases. I have to say, I believe the research pans out that a lot of this, unfortunately, is family members, whether it is immediate or extended. The danger for courts is to mistake these symptoms of self-neglect when, again, it could be elder abuse. And really, what interventions can we put in place to protect those individuals? And some of it is guardianship, right? If that individual is determined not to have capacity, okay? All right. Is this you, Carrie, or is this me?
I think it's both of us. If you have more you want to say, otherwise I can chime in.
Okay, let me go ahead and give you a John Doe fact case, right? This is
Oh,
a lady.
oh,
What's
I'm
that?
sorry. I just wanted to interrupt
Yes, please.
on the intervention in the self-neglect cases, recognizing the rights of older people. So the one thing I just kind of wanted to pause on that is to be thinking, when you have cases that you ultimately determine based on the science and the neutral and objective facts that are before you, that the person is not incapacitated, all right, but they are suffering self-neglect and or elder abuse. You will often have family, right? Many of these cases are coming to us because family members have brought the case before the court. If you determine it is not appropriate to establish a guardianship, but you do think it is appropriate to do something else, there's that push and pull of being the objective sort of referee. And judges feel like I can't be an advocate, right? I'm not allowed to be an advocate. Cases come before me. I call the balls and strikes, and people go their own way. But that's not really our obligation, right? Our obligation is to uphold the integrity of the justice system. And part of our upholding the integrity of the justice system, which we know over and over, and we're hearing over and over again in terms of procedural fairness, is taking the time to explain to litigants what we're doing and why we are doing it. And in the context of explaining what we are doing, or in cases where we determine guardianship is not appropriate, we can take the time to explain why we are not imposing or drafting that guardianship order today. And in doing so, we can also say it is not appropriate for us to establish guardianship because this person has capacity. However, after an evaluation of the facts and evidence in the case, it may be appropriate that this person apply for a vulnerable person's protective order, whatever that is called in your state, and that this case could be more accurately and appropriately addressed under a protective order. So at least when people are leaving the courtroom, they're not walking away thinking, oh, the judge doesn't care that, this cousin or this nephew is, doing these things to my mom or dad. It's just that this particular case before us was not the right case. You may also, many states have mandatory reporting. Oregon is a mandatory report state. If your state is, then if you hear facts and circumstances that result in elder abuse, you are required to notify either law enforcement or your adult protective services, whatever that is called in your state. So even if you determine the person has capacity, but you've also have a strong conclusion that elder abuse is occurring, then it is your obligation to also report that to law enforcement. And would go ahead and make those findings on the records. You can say something like, I have significant, suspicions that there may be elder abuse. As a mandatory reporter, I am referring this. So if Adult Protective Services gets in contact with you, please understand that's why. So just because you can't do one avenue because it's not legally appropriate or doesn't comply with the statutes in the case, doesn't mean that you, number one, shouldn't take the time to explain to all parties your reasoning and why you did it, and also refer them to other avenues or places where the actual issue can get addressed so that they're not walking out of the courthouse going, oh, well, I guess elder abuse is okay, which, as we've seen from disgruntled people, when they leave. So sorry about that. Go ahead, David. Or Dr. Franklin. Oh, I guess I'm supposed to do the John Doe facts too. All right, so let's talk about John Doe. This is another situation that you might often see. Dr. Franklin says the sweetheart scam. So maybe be thinking about that as you're hearing the facts in Mr. Doe's case. So Mr. Doe is 80. He's living with his wife, who is 60, in a senior living community. She invited the stepdaughter to come and stay there, which is against those rules of the senior community. We know that the wife and the stepdaughter say that Mr. Doe has approved large purchases, meaning, let's say, expensive purchases by the stepdaughter. We also know that somebody called Protective Services on behalf of Mr. Doe. And so what they observed is that Mr. Doe has bruises. He has bruises on his chin and his arms. When asked, Mr. Doe has said that his wife taps him to pay attention, as we all do, hard enough to cause bruising, right? She denies that she's caused the bruising, and she says that his brain is mush, right? So she's undermining his perspective when he's speaking to folks. He has two sons. One they can't find. One has declined to be involved, it's probably because they don't like new wife, right? Since the current marriage. And we have an assessment by someone as capable as Dr. Franklin, we hope, in performing a major and the results showed major cognitive decline. However, Mr. Doe is capable of handling some simple tasks, but just not the more complex tasks. So when we are evaluating Mr. Doe, let's talk about, again, in the chat, let me get my chat open. What do we think so far are some relevant facts that we've learned based on what I've shared about Mr. Doe? Let's assume that he is before us on a guardianship issue, at least initially.
So Judge Long put something in the chat, Carrie. Did you see that?
Ah, thank you. I had to scroll down. Judge Long, clear injuries without an explanation. Right. So we know that he has bruising, which is an objectively observable thing, right? People can suffer bruises, but we want to know the heart of the bruises. Where are they coming? How often are they seen? What do the independent folks say about the bruises? We have Mr. Doe saying he's receiving them because of tapping, but we don't have any other alternate explanation, right? We just have a denial by Mrs. Doe, but we don't have any other alternate explanation. So for us, these are unexplained bruising, which should always be a red flag, right? In any cases, when we have folks before the court without an explanation for that bruising. What other things are you concerned about in this fact pattern? The stepdaughter engaging his living situation. So, what is it? I guess if I was the judge hearing it, I would be wondering, first of all, why is stepdaughter there? There are clear rules about stepdaughter not being there. And so what are the circumstances that first of all allowed stepdaughter to be there in violation of the rules? And then you might be concerned, at least I was concerned a bit with the fact that we have sort of the collaboration or ganging up approach between wife and stepdaughter, right? We have the situation where wife is saying, "Oh, his brain is mush, and he approved these purchases." And so when we're talking about purchases, so financial exploitation is obviously one of the key issues in elder abuse cases. And as Dr. Franklin mentions, a lot of times that's going to be the people that are closest to them, right? The people who have, quote, permission to be using the person's funds. And at least the statutes likely vary a little bit throughout the states. But if a person in Oregon, for example, is stepping into that care provider role, then they cannot exceed the scope of that care provider role. So if Mr. Doe says to stepdaughter, "Here's my bank card, and I give you permission to use my bank card to go and get groceries for us," and then stepdaughter goes out, buys the groceries, but also then takes another couple $100 cash back, then she's exceeding the scope, number one, of the permission, right? But then she's also taking things for her own benefit. So these are things to be thinking about when you are evaluating the John Doe facts. We're getting to my sort of favorite slides coming up. And I think that if you take nothing from this, you should take away Dr. Franklin's cognitive, right, impairment roadmaps and assessment information. And you should take our slides coming up called the basic roadmap to evaluating these cases. So be thinking about, again, when these cases are before you, think about crafting orders that promote their own self-determination, that continue to give them as much liberty and freedom as they can, that you identify their least restrictive alternatives, and that you can make determinations as to whether at some point capacity might be able to be restored. Is it appropriate to establish a temporary guardianship versus an overreaching long-term one? And what safeguards can you put in place to reduce potential elder abuse and undue influence? So let's talk about my favorite couple slides coming up. Dr. Franklin and I are going to kind of give you this question-based roadmap to be thinking about when these court cases are before you. Take it away, Dr. Franklin.
Okay, so looking at, let's see here, is this case a temporary? Where do I start, Amanda? Do I?
So
I
let's
apologize, I hit wrong. Yeah, some of these questions are more legally based and some of them are more medically based. So I think you guys can share these two.
All right, great. So let me start. Do you want me to start with is guardianship necessary and helpful, Carrie, or how do you, which one do you want me to go ahead and do?
So let me start by just kind of thinking about this critically on the how does the issue get before the court, right? So how does somebody get the paperwork filed? How does somebody come into the halls of the courthouse, right? Because it's important to know who is the one that brought the action, because people bringing the action may be the same people who are perpetrating elder abuse. So be critical in thinking about how is this getting before me? Is it a neutral, objective body, perhaps like a doctor or a hospital facility or some other neutral person who doesn't have a sort of staked interest in the case? Or is this someone who, is a loving and concerned family member that really wants to step in and try to help and care for this person? So really be thinking, first of all, how did this even come in? And then once it's in, the question on have all procedural requirements been met? Many states, I'm not sure if it's all of them, but many states will allow appointment of guardian ad litem or some other temporary guardian that is going to be the advocate for the person, protected person that's before us. Has that person been appointed so that that person has a voice, right? Have you made sure to get notice out to everyone regarding this proceeding so that we can actually make sure that we have an opportunity to hear from all interested parties and that there's that opportunity for critical analysis that's usually afforded to us by cross-examination of witnesses? I just want to pause briefly, even on the question on the road-based roadmap, to just be thinking about, in terms of procedural fairness, how is your courtroom or courthouse designed? How open and welcoming are you for folks that may be suffering elder abuse, have capacity issues? How can we make it easier for the information to come to the court? And so very simple things like, do you have access to the courtroom? Can people get in through the doors of your courtroom? Are they wide enough? ADA type things. Is your courtroom set up to be able to assist people who may need hearing devices? Is your courtroom set up? Is your docket set up so that you can move the timing of these types of hearings so that you can get people when they are at their best? If you have a hearing like this and you have the flexibility, ask the prospective protected person what time of day would be best for you for the hearings. Some people sleep until noon or 1 and really don't function well in the morning. If you have the capability, please think about scheduling it in the afternoon. And then we get into the actual sort of statutory and legal analysis as, is this guardianship necessary? What should the scope of that be? Should it be temporary? Should it be an emergency? What type of information are we going to want from our neutral person, like our Dr. Franklin's, in helping us make those determinations? So, Dr. Franklin.
Yes, and so when we get into the issue of reports and the clinical evaluator, right, as we discussed before, knowing that evaluator is extremely helpful. And in a lot of instances, we do not know who the evaluator is, but understanding their credentials, right? As I mentioned to you before, we don't want a podiatrist going ahead and making a decision on capacity, right? And I know in some states, it can really vary as far as the healthcare professionals who perform that. Also, the medical cause of the alleged incapacity, right? When I sometimes deal with individuals who are not in the moderate to severe stages of a neurodegenerative illness, but maybe due to a traumatic brain injury, or I really don't know the etiology or cause of the impairment, I may suggest, hey, look, we need to do a temporary conservatorship because at this point in time, the person, I believe, is deemed not to have capacity to make decisions. I may put in my report, I want to recess the person 6 months to 1 year from now to assess where their capacity is at that point in time, right? Because you may deal with tricky traumatic brain injuries where there may be, it's not progressive, but they may actually improve over time, right? But at that point in time, they are deemed to not have capacity to make certain decisions, or there's financial abuse by another individual toward that individual, or protecting that individual, because that's the last line of defense for this individual, right? Or I may see a person who might be actually in a delirium, okay, just by happenstance. And if I have a feeling like that, I'll put in the evaluation. I want to reevaluate 6 months from now to get an idea where we're really at, to make sure that what I'm seeing is really what's happening in front of me. You have to remember, a lot of these people who are doing these evaluations, or you should remember that a lot of people who are doing these evaluations don't know the patients very well, right? When I come in and go in the home, I'm only with the person for 2.5, 3 hours at most, right? So I'm getting a snapshot. I sometimes have or ask my APS social workers or law enforcement agencies to see if the primary care physician or geriatrician can do the capacity declaration, but make sure there's no conflict of interest or any of those issues, because they know the patients better. But I'm walking in with a snapshot, and I understand my limitations and recognizing those limitations, right? To ask for those retained capacities, or to reevaluate and have that ability to reevaluate, but instill a temporary conservatorship in the meantime or ad litem. So that's kind of some of the issues there.
I just want to chime in too on the issues of the medical causes that may be temporary and diminish over time. If you have any indication of that, I would urge you then to calendar or docket out a review hearing that aligns with sort of the timeline for anticipated recovery of those issues. Sometimes that takes a lot of extra effort and or docketing. Some folks wait until there's an issue and allow the parties to contact the court to put it back on the docket. But certain times it is appropriate that you actually take that proactive measure to do it. And I would urge you to really be thinking about it in terms of your elder abuse cases. When you have the elder abuse cases where you know that you have identified the perpetrator and now protections have been put in place to protect this person, you may find that once the perpetrator is removed from the situation and the person now is able to get adequate hydration, adequate shelter, adequate food, adequate, safe and, appropriate living circumstances, that the reasons for their incapacity diminish that as they get healthier over time. And so please don't let that sort of blanket guardianship that you needed to put in place for that sort of emergency circumstances be then the facts for that person or the circumstances of their life going forward. All right. And so let's go to the second slide on the question-based roadmap. We've got one we are. So I think when you are considering crafting these orders, be thinking about what level of supervision is needed. A lot of our statutes are so broad, right? They just allow us to do whatever is reasonably appropriate. The custodian or the guardian is able to take what reasonable care and reasonable efforts. And that gives people a whole lot of leeway, and I think allows an invitation for overstepping, overuse, and unnecessarily curtails people's, some basic liberties. So have that conversation when you are crafting the order, talking with the person, if you have them available to you, the proposed protective person, and also the guardian, so that they understand the limited scope of what they're going to be able to do. So for example, you might give that person the authority to be able to find housing for the person, but you may also require that that person come back to you to get approval for that housing and justification for that housing, because there's a difference between putting somebody in a senior home where they can come and go freely and still go out to the movies and go to cars, ride in cars with their friends, versus the type of facility that may be needed to keep a person from wandering. And so it's more of a locked or semi-locked facility. And before we put someone in a locked or semi-locked facility, there really needs to be a good and legitimate basis for that. And so you may, in a particular case, determine that you'll allow the person to make, decisions on housing and living for the person, so long as it doesn't restrict freedom of movement. And if they want a different if they want a different finding, then they can come back to the court on some sort of expedited basis. All right, I did put in the chat that we would be wrapping up shortly. So if you had any questions, we want to make sure that we've given at least a couple minutes to chime in on those questions. Dr. Franklin, anything else by way of wrapping up?
Let's see here. To Dr. Free, regardless of normal court procedure, how often would you want to see guardianship orders reviews, or is strictly dependent on diagnosis? And if so, what do we do from the bench? This is a really good question, is how often do we do this, right? And psychiatrically ill patients, what we call LPS conservatorship here in the state of California for people who suffer from severe mental illnesses, that's reviewed every year It has to be signed off by psychiatrists and psychologists, right? So that's kind of nice in that respect. When dealing with probates, it's much different. And honestly, you know, for me, I look at it on an individual basis, right? And that's why I put it in the reports that I want to see the person back in a year or 6 months. But those that are severely impaired, and you would be able to see those in the courthouse. And by the way, I always mark that the person should be available to be at the courthouse. There's not a time where I've not had that person who are about ready to take their rights away, not be able to be at the courthouse in some way or fashion. And as Carrie mentioned, sometimes altering the courthouse so that we can do televideo feeds and things like that, especially during this time of COVID, right? So, and there shouldn't be a reason why that person isn't there. But you can get an idea and breadth or sense of how severely impaired that person is. If the person is severely impaired, doesn't know what the date is, doesn't know what day of the week is, doesn't even know what city they're in, and you'll see these come across the bench, right? I wouldn't suggest that another evaluation be done immediately or a year or 2 or 3 years out, to be honest with you, because now you're seeing the progression. For those that are more in the earlier onset of the illness, so they may have what's called a major neurocognitive disorder, but it's not global. It's not affecting all areas of the brain. You might see that come across your assessment as well too. You may want to bring those a little bit in earlier, maybe a year and a half, 2 years, to see kind of where they're at. It's the ones where the injuries or the etiologies are a little bit different, like traumatic brain injury patients, right? As long as they're not really severe, where they've been in a coma for a month, you might want to see those a little bit earlier. Okay, and I'd feel a little bit more comfortable seeing those earlier. Some of my dependent adults that come in as well too. So that's kind of what I look at. It really does kind of look at diagnosis and individually. And that's why I put it in my reports, that if I have concerns that I don't know exactly what I'm seeing, I'm like, you know what, I want to see this person back in 6 months or a year. And I'll put that in the reports. I suggest also sitting down and getting that information from the examiner that's doing it as well too, Judge Long, and to get their terminology. Hey, look, do we want to see this patient back or not? So, and what do you suggest as well as an expert in this field? I hope that answers your question.
I'd like to just chime in that regard. Many of us have practices in place where we're tracking these cases, whether or not we require annual reviews, 90-day reviews, year reviews. Sometimes a review in your courts are going to vary. Sometimes it's a written report that you just expect the person that you've appointed to be the guardian to provide a written report. Sometimes it's something more comprehensive, like you want updated medical records, you want updated financial records, and I think if you do these cases routinely, you can kind of get into a pattern of what you expect to see by way of, your reports, 90 days, 180 days, or a year. But please just be thinking from time to time to really, kind of jog yourself out of the rote sort of review and really be thinking, has it been a while since I've actually critically looked at this case? And do I need to do a critical analysis? Is it time for a new assessment or a new evaluation? Because the facts might really drive that.
Great. Thank you both so much. We're at time, so we're going to wrap up for today. Please feel free to, if you do have additional questions that we didn't get to or you didn't get into the chat in time, please feel free to email us. We will be emailing out the slides, and a recording of the webinar will be available on our website within a few days. And thank you again, and have a great rest of your day.
Thank you everyone for attending.
Thank you. Bye-bye.